Now in this video we are going to talk about the blood transfusion. It is the whole blood and not the blood products or the fractions of the blood. Now who should be transfused? Patients who got hemoglobin of 7 gram per deciliter or less, and cardiac patients or patient undergoing the orthopedic procedures, this value is at 8 grams per liter as cutoff. So these patients may be transfused. In patients who are actively bleeding, these parameters may be different. For example, even at higher hemoglobin, patients who are actively bleeding may be transfused because they may be losing blood and the initial blood sample may not represent the true blood loss. It is after the patient becomes stable, the vitals are normalized, the circulatory volume is restored, we actually know what is the drop in the hemoglobin or hematocrit. So patients who are actively bleeding, they may be transfused even at higher hemoglobin levels if they have any evidence of hemodynamic compromise. Then should it be the whole blood or it should be the packed red cells only? Preferably it should be packed red cells, only red cells should be infused. But if the patient requires volume as well, so sometimes we may transfuse the whole blood. For example, if the patient is bleeding and we require the volumes to be restored, the whole blood may be transfused. Otherwise, it is the packed cells which are the better option to be transfused. And one pack almost improves the hemoglobin by 1 gram per deciliter. So our target can be decided that how much transfusion should be given to the patient. Now, what are the prerequisites? Do a proper grouping and cross-matching. Go for a need assessment. Does the patient really need blood? And what is the cardiorespiratory or cardiovascular reserve of this patient? If this is compromised, you have to be very careful because potential problem of transfusion is cardiovascular overload and patient may go into decompensation. Assess for contraindications if there are any. Usually there are no contraindications. It's the cardiovascular system which is compromised, or sometimes there may be, for religious reason, there may be some contraindications. Otherwise, generally no contraindications for blood transfusion. It is the indications which decide are we going to transfuse or we're not going to transfuse. Now we see what are the complications of transfusion. You may have febrile reactions, patient may have transfusion associated circulatory overload, there may be allergic reaction, patient have transfusion associated lung injury, there may be transmission of infection like hepatitis C or HIV, and then there may be fatal hemolysis in some of the patients. This is fortunately a rare complication if a proper grouping and cross-matching is done before transfusion. Now we see these complications one by one. Febrile reactions, you see, these are more in patients who got leukocyte-rich products. If they are leukocyte-reduced blood products, the febrile reactions are less. When there is a febrile reaction, stop the transfusion. And consider hemolytic workup because the hemolytic reaction in the beginnings is similar to the febrile reaction. Then go for the infectious workup, as generally acetaminophen is sufficient to control the symptoms. In some of the patients you may need diphenhydramine for symptomatic improvement. And then you got volume overload, that is circulatory overload. Patient may have respiratory distress which is secondary to pulmonary edema. It's a cardiogenic pulmonary edema. Patient may have CCF or ARF as predisposing factors, so this develops more in patients who got congestive heart failure or acute renal failure. Usually the onset is within 6 to 12 hours of the symptoms. There is elevated BNP and these patients respond to diuretics. So you limit the transfusion to lowest amount necessary, the slowest possible speed, and diuretics before or during the transfusion may prevent the development of clinical symptoms. And then allergic reactions. Again, patient may have urticaria and pruritus. These are in less than 1%. More severe reactions like wheezing, anaphylaxis, bronchospasm are fortunately rare complications. Patients who are IgA deficient, they may be more affected because the exposure of the IgA product from the donor may cause problems. Antihistamines may be required in some cases who got severe problem, bronchodilators, steroid and epinephrine may be required. And then patients may develop TRALI, that is transfusion associated lung injury. This is just like adult respiratory distress syndrome. Within 2 to 4 hours it develops and it is without features of congestive heart failure. So it may be called as non-cardiogenic pulmonary edema, which develops because of the transfusion-related lung injury. Chest X-ray shows diffuse patchy infiltrates, got a very high mortality, 10%. 90% of the patient resolved within 96 hours with supportive and conservative management. Then fatal hemolysis, this is one very serious complication. Acute onset of fever, chills, low back pain, flushing, dyspnea, as well as becoming tachycardic and going into shock. So these are the clinical features. There are fevers and chills, backache, flushing, and shortness of breath. Stop the transfusion immediately. Keep the IV on, start IV normal saline to keep the urine output around 100 ml per hour. Sometimes, if required, diuretics may also be used. Cardiovascular or respiratory support as appropriate should be offered to the patient. Hemolytic workup should be performed. Retype and cross-match the blood from the tubings, and direct and indirect Coombs test should be done. Complete blood count, creatinine, prothrombin time, APTT should be drawn from the other arm for analysis because that arm may give false reports. Peripheral smear may be done. Hemoglobin, indirect bilirubin, LDH, plasma-free hemoglobin should be tested for hemolytic reaction, and urine analysis for hemoglobinuria. Then infections, hepatitis C, HIV in less than 1 in 1 million. Bacterial infection in 1 in quarter of million. Red cell pack transfusion may be seen in these patients. Then we got electrolyte abnormalities. For example, patient may develop hypocalcemia because citrate in the blood binds calcium. Patient may have hyperkalemia from a release of potassium in the stored blood. So if the blood is stored for longer durations, there may be hyperkalemia. This is seen more in neonates and patients who got renal insufficiency. And then some of the patient may show hypokalemia because of alkalinization. Citrate is converted to bicarbonate in patients who got a normal liver function. So that may alkalinize the blood and may result in hypokalemia. So these are the complications of transfusion. Generally, they are manageable. And if the patient selection, the grouping and cross-matching, and the transfusion arrangements are properly done, transfusion reactions are usually less common.